We're going to move into back into sort of more traditional thinking about virtual reality. And one of the, I guess there's an eighth that we need to, there's a period we need to put on this conference, which is, okay, there's a lot of people that are asking questions about how can I actually do this work? How can I study whether or not an intervention is helping, whether it's actually making a difference? And the state of the art right now is quite chaotic. There are all sorts of different studies out there with different designs and different outcome measures. And what we're going to hear about today is a new set of guidance that Brandon, who I've already introduced, will present to us from an international working group. And he's going to present a new framework. Just like the FDA has phase 1, phase 2, and phase 3 trials, what he's going to tell us about today is a new framework of VR1, VR2, and VR3 trials. So come on up on the stage and tell us what this new framework looks like and why it's important.
Thank you.
Thank you.
Yeah. So we'll start up with that. Thank you for the introduction. Just a couple pictures of some of the first patients I got to treat with VR. I kind of cut my teeth in VR a couple years ago with dental anxiety and trying to figure out a way to do head-restricted VR, which was a really interesting challenge. I like to start with kind of a chart of optimism for myself. So Dr. Danovich talks about publications and the rate of them increasing. Something that we don't even see here with a great rate of increase is that the technology enables me, a young resident physician, to do research or to create a study. Because essentially, back in the early 90s, it would have been almost like half my paycheck to buy a headset, and it would have been 30 pounds. And now, since a lot of these other innovations that we've seen, you can start a cold pressor test or an ice bucket related pain tolerance test for about $400, at least for that first study that I created. And it's ongoing at Mayo Clinic. So one thing we want to talk about is, again, scientific rigor and how do we get to be comparable to what's seen in other modalities, pharmacotherapies. And so the first thing that the team at Cedars-Sinai that we did was that we looked at the current literature using meta-analyses to look at randomized controlled trials. 40 of them met criteria, which we'll save for another time as far as the exact the criteria that we specifically used. But the important thing is we were looking at risk of bias. And there's a really important tool called the Modified Cochrane Risk of Bias tool. And this helps us see what's a concern and what has been done well over the last 20 years, or 15, 20 years. And so what's been done really well is randomization. People, or at least in randomized controlled trials, they randomize well. They reported if there was any selection of data. They reported if there was bias. But the four things that are challenging for digital interventions overall. One of the best clinical trialists at Mayo Clinic once said in a lecture that you can't blind, which, try to cover someone from seeing their intervention versus control. You can't blind a digital intervention. The lights are on or off. I agree with him for many digital interventions, but actually head-mounted displays, I'm going to show you by the end of this talk, there's a couple ways you actually can, and improve the quality of your study. So how do we improve? Brendan contacted me back last May and said, hey, we should build a team. I said, absolutely, let's do it. So reached out to the community, looked through Google Scholar, and connected to the VR community, and found several individuals interested in having kind of a dialogue about what would be the important challenges. And thankfully, we have several international members. We're going to hopefully have some more from the UK. We'll have some from Belgium, and a few more from the US. And we encourage more because there's so many different uses in this. And we need to ask better questions. Some of these, Dr. Diane Grommel is actually a computer scientist, and her perspective as a researcher and computer scientist, far different from Brendan's or mine, and it's, all the conversation has been quite helpful. So what are the current perceptions? And the perceptions currently is the lack of guidance. How do we do this? Are we just being descriptive at this point? And also a need to, to know that we're at an early stage, and it's understandable where things are at, but how do we go to another level? And what's really interesting is the participatory design. So many of the providers said we need to engage the patient. We need to get them involved, and we need to look at this. We need to add other team members, behavioral scientists. We need to, of course, overall improve how we describe these interventions. So these were some of the quotes from our discussion online. And then we also try to look at what's been done with clinical trials. So there's usually a preclinical phase, maybe some animal models, in vitro, in vivo models. Then you would start with a safety trial, small amount of patients. Then you would increase the amount of patients so you can try to test efficacy. And so the VR core came together, and after the discussion, we felt that we should try to, the major change is that VR1, creating the intervention with the patient, because this is all an engaged intervention through human-centered design, which I'll talk about in a second. Then you need to have an intermediate step where you have to ask a lot of key questions, which many of the early adopters will know is pretty important to ask. And then, of course, randomized control trials. So I want to state at the get-go that this can work for any device on the spectrum. Though we did focus on head-mounted displays, this can work for our rehab specialists that are using non-immersive VR. Other experts are using CAVE, mobile AR, which has become more popular in the last 2 years, and of course the mixed reality, the new frontier. So what is human-centered design? And I think from me, essentially kind of learning as I go with this, is that it's a way of getting to know people that's quite different from what I've been trained to do. I think I sometimes feel like a search function for signs and symptoms, but I think that getting to know someone from their perspective, what's their relationship to technology, what's their expectation, will absolutely dictate to some degree your potential total impact. There's a great resource, hopefully you get the slides later to learn more about human-centered design, but it's a cyclic process, and I think that's really interesting to gain observation as much as you can, input from the patient, from the user. Get together with your team and come up with as many ideas as you can, and then iterate quickly and affordably, and that's something I actually, saves me time now to think about this. So what's an observation step? It's early on. There's probably only a couple studies right now that are really human-centered design focused, but I think the SoHelp trial was actually a great example of finding someone in a comfortable environment and eliciting from them what's important, and doing it through, of course, focus groups or cognitive interviews or assessments. And then also the VR core really made it a point to say we need to talk to the people providing the intervention. And so, also mapping this all out and saying where in this process does the intervention need to go. So group ideation, you'll see lots of notepads or stickers, whatever colorful organization tool you like to use, but sharing it with your team, creating a huge group of ideas, because some of them will work, some of them won't for reasons, as you pan it out. But then you have to go through a funnel process and find the most appropriate, feasible idea for your constraints, whether it's budgetary or maybe it's a technical concern. So the most impactful thing for me through learning this VR1 and human-centered design process was the thought of doing proactive design with someone instead of reactive. I think I've actually not wasted time, but to some degree with my early projects, I feel like I had an idea, but then you always have to engage and you'll get feedback later on. Do it from the beginning. Do it with initial mock-up, get up feedback, go through several iterations before you even get to the point that you're at, a minimally viable intervention. And try to record positive and negative results, because overall we'll start to read publications and say for this whole genre, what's that demographics concerns, and it'll benefit everyone in the community, at least we hope. So I purposely put VR1, VR2, VR3 in between our current trials format, because it was made for a different type of chemical intervention, and to some degree there may be gray lines between these, at least we think. So talking about an intermediate step, why is the intermediate step important? That was actually a question that came up from a lot of people in the VR core. And the importance of the intermediate step is willingness to try the intervention. There's been a lot of feasibility studies talking about the digital divide. Certain age group of patients may not have the same, for several of their own reasons. why they may not want to engage with that head-mounted display. And that should be recorded because there may be other devices on the spectrum that could fit that patient population. We don't have to be prescriptive to one technology. It's not the technology, it's the endpoint that you're trying to get to. Feasibility is looking at kind of the flow of care. I think that's something we all probably can imagine in certain situations where I don't think VR works. And so you need to be able to know what those barriers are, find the cause, and in my mind, I like to think there's always a hardware or software fix for it, or some other type of fix. Talking about frequency, we thought that frequency and dosing would be something you could figure out at the intermediate stage, because you've gone through that process with the patients in VR1. Now is the time to see if multiple doses are actually something your intervention can do, or is it a one-time deal. Tolerability is something we've seen, and probably, you could imagine would be something you want to record, especially discomfort and convenience can happen quite often, but also, physical effects, and are the patients going to have an emotional response to your environment? So one last thing for VR2 is try to find a clinically relevant patient outcome. Thinking back to work that I've done prior to VR, it's very tempting to try to do something that would be research you can achieve, but maybe not necessarily move the needle. And I think we really need to push to try to move the needle on that endpoint. Also, validated scales. It's hard to get in the early days of an intervention, but if you can't, just clarify your choice. Doesn't require a control arm. This is intermediate step. There's several modalities to use that you could try to make a comparison, but it's not necessarily required when you're just piloting something. So we'll get to the final stage, and so that's the VR3, and that's really where you want to, with the greater power comes great responsibility, or just you have to describe it well. You need to be able to say who's going to be involved in this and who's not, because the end result, positive or negative, will dictate to some degree maybe that intervention's use. And we at the VR Core talked a lot about exclusion criteria. There may be certain things that we universally could say, maybe it's not a good idea. If someone has one eye and they're doing a depth perception-based headset, potentially that's not a person that may need to be excluded. Or if they're having active nausea and vomiting, or active epilepsy, there's certain criteria that we're maybe not there yet as far as standardization of many things, but that might come down the line. And also recording who that patient is, and creating a flow diagram of who goes in and who doesn't finish the trial. All this, what I would say is, there's a website at the bottom of this, consort-statement.org. If you just go through the process of looking through those protocols and just trying to fill that out when you're making your study, you probably will be better off than the vast majority of current studies. It's a great resource, and the titer is another template on that website, and they go through a process of describing your intervention. And we may be not a decade away, but we're probably several years from standardizing who gets what for what disease. But if we describe something well enough, then I can say Snow World may be similar to Banana Blast or whatnot. We need to be able to understand what people are doing and not just say, you may need to put a slide or a screenshot or a video. This part was by far my favorite part of the conversation. I guess I shouldn't have a bias, but I do. I really love the idea of talking about controls. What is a control? What are you making a comparison to? Ethically, there are understandably maybe some conditions where you can't use anything. You just use your gold standard of care. But almost all of us have a computer in our pocket, and to some degree that can have an impact on us. So having something like a passive visualization or a tool like a tablet as a comparison may be an appropriate one depending on your patient population. What I'm really excited for, there are a few studies that look at headset. You're still using the headset, but use a non-immersive program as your control. So just have a video, just have what I call void theaters, and use those as your comparison because they're non-immersive, and play play a recording of your actual intervention if you'd like. There's a few studies that have done that. And the next stage would probably be doing immersive program with another immersive program. What do you feel like is the actual mechanism of action? Is it the color? Maybe it's Jeremy's soundscape, have verse one and verse the other. And so we're really scratching the surface, but that's, at least right now, what we think is potentially appropriate, an active control of some kind. Blinding and concealment. So considering the gold standard right now of randomized controlled trials is usually a double-blinded or a triple-blinded. So double-blind, the patient doesn't necessarily know what which one's control versus the test pill. The doctor, the specific doctor doesn't know what's the test pill. The people that make this study may ultimately know. And then a triple-blind would be the person recording the results doesn't necessarily know. So there's a lot of masking that has to go on in a randomized controlled trial. It's actually quite pricey to do it because of this reason. So what does the VR core say about this? Generally, they think that blinding the analyst is something that can be done at any time. You essentially just have to have another person in between, someone recording and collecting. That we think that at a minimum could be done. Blinding the patient and the provider is challenging, but there are a few tips that we found out from just discussion with the group that have been trialing this out. And that is, patients, you could have your consent form. And if you're doing something like a tablet or your VR immersive headset, if you say that what you're going to be using is an audiovisual tool, both are audiovisual tools. You don't necessarily give them the expectation that they're going to have this brand new technology that may change everything. So they don't have to feel upset about that decision point. Another one, which again I think is coming down the line and has been done a few times, is again having it within the headset and having a non-immersive control. The provider and the patient in that situation would be blinded from it. Another thing, concealment of allocation. What does that mean? Concealment of allocation means so if I create a trial, I shouldn't know who is going to be in which arm. And that's something one member has done before. It's technically somewhat challenging, but she actually randomized between two programs. And so that's another potential solution that we'll probably see in the coming years. And so there's so much more, in the paper that we wrote with Brendan and I and several of the other team members that talk about so many other topics. I would just say that for one thing I will say is there's several people in your team you should just trust and you should have on your team. So, a behavioral health expert, a statistician. If you're getting to the point where you're at the VR3, sometimes I think I understand stats, and then I quickly find out when I talk to a statistician that I do not know stats as well as I thought I did. So you just have to trust certain team members. It's a team effort. And so, there's a great paper at the bottom of this as well that we reference, and it's called the Ideas template. It's another group out at Stanford made it. Highly recommend reading that as well. One thing I want to say is that the team, understandably, is concerned about the cost that goes on with a VR3. It's expensive. A randomized control trial is not something I'm going to be able to afford for maybe a decade or so. But I think if we work together, whether that's the VR Core or another organization or just working with several hospitals, if we can get to the point where we're looking at 1,000 patients. I know Dr. Rue says there's a few potentially down in Australia that are working to do large trials. And so we could collaborate together on this effort. And I think it's a hope for that. And I just want to conclude with why are we doing this? Patients, several patients suffer a great deal, and they deserve the ground truth of whatever we're doing. We need to get to the ground truth as quickly as possible because it's in their best interest and it's the right thing to do. So I just want to thank Dr. Brendan Spiegel for allowing me to collaborate with him on this project and the CSIN team, and also the VR Core. We'll be having more studies soon to think about other important questions. So thank you.